Reminders to all the attendees, you may type in your questions regarding the lecture in the chat box and the speakers will gladly answer them for you. Or you may personally communicate them by sending a message to the email provided on the screen. We would also like to request everyone to answer the evaluation form after the last speaker of the session. Link will be seen in the chat box. Our second speaker for tonight is a fellow of the Philippine Pediatric Society, also a fellow of the Philippine Academy of Pediatric Pulmonologists, and a fellow of the Philippine Society of Critical Care Medicine. She also had her fellowship on pediatric pulmonology and critical care medicine at the Philippine Heart Center. She is currently the research coordinator and member of the Technical Review Board of the Clinical Trial and Research Division ETRS of the Philippine Heart Center. On top of that, she is also the Quality Management Representative Head of the Office of Strategy and Quality Management of East Avenue Medical Center. To share to us the updated guidelines on pediatric community-acquired pneumonia, let us all give a virtual welcome to Dr. Nerissa De Leon.
Good afternoon. My topic for this afternoon is in pediatric community-acquired pneumonia and its updates. I am Dr. Nerissa De Leon, and before I start with this presentation, I would like to thank the organizers and the Philippine Foundation for Lung Health Research and Development for this opportunity. Although I am a member of the PCAP CPG Task Force 2021, a joint collaboration of the Philippine Academy of Pediatric Pulmonologists and the Pediatric Infectious Disease Society of the Philippines joint collaboration, I will not be discussing the updated PCAP CPG in this afternoon's presentation. But for this afternoon, my learning objectives and I would want to discuss are key points and issues as far as the burden of disease, the diagnosis, the ancillary tests, whether laboratory or imaging, and the management of pediatric community-acquired pneumonia is concerned. What is the burden of PCAP or pediatric community-acquired pneumonia? In 2016, as reported, for children younger than 5 years of age, there is about 0.11 case per child year or 68 million episodes for that particular year. It is actually the sixth leading cause of mortality worldwide that accounts for 13.1%. In Southeast Asia, it accounts for about 18.2 deaths per 100,000 cases and 36,100 episodes per 100,000 children. In the Philippines, it accounts for about 1 for every 5 child admitted. What is the global burden, the global deaths, fatal attributable fraction, and episode due to the lower tract infection etiology for children less than 5? If you look into all of this, just keep your eye on the first column and on the last column. The most common etiologic agents concerned are strep pneumoniae, respiratory syncytial virus, H. influenzae type B, and influenza. And strep pneumoniae accounts for about 70.7 incidents per 1,000 children. RSV accounts for 17 cases or incidents per 1,000 children. H. influenzae type B accounts for 9.6 per 1,000 children, and influenza accounts for 9.1 per 1,000 children. The risk factors for lower tract infection, and this is actually the Philippine data as shared in 2016 and published in Lancet in 2018, whether it's how many children develop pneumonia or what are the risk factors in the development of pneumonia per 1,000 cases or per 10,000 cases. This can be lumped into just 5 main factors. Number 1 is the state of childhood malnutrition or the nutritional status of a child. Number 2 is the presence of or exposure to air pollution, whether that air pollution is within the household or the biomass fuel that is produced, ambient particulate matter, or secondhand smoke. The third factor is the accessibility to vaccines like for pneumococcal vaccine and your H influenza B vaccine. Number 4 is adherence to health protocols like hand washing and exclusive breastfeeding. And number 5 are the use and misuse of antibiotics, and for which we have the AMS or the antimicrobial surveillance program that is in effect at present locally. The burden of pneumonia is that pneumonia can become complicated in about 3 to 70.1%. And the complications of pneumonia are in the form of empyema in 4.4%, lung abscess in 0.9%, and necrotizing pneumonia in 0.8%. So what is pneumonia or pediatric community-acquired pneumonia? It is an acute lower tract infection in a previously well child or an immunocompetent child with associated symptoms of fever, cough, dyspnea, and tachypnea. And this we have known for more than a century, with supporting evidence of parenchymal infection and inflammation, like auscultatory findings on the chest and presence of focal opacities on chest radiographs. So that even if with a normal chest x-ray, but in the presence of chest auscultatory findings, we do make a diagnosis of pneumonia. So how does it impact on how we manage our patients with pneumonia? The recent WHO classification of pneumonia in 2014 lumped fast-breathing pneumonia and chest-indrawing pneumonia into plain pneumonia, which is the presence of cough or difficulty of breathing associated with fast breathing or chest indrawing in a child 2 to 59 months of age. And made another classification of severe pneumonia are those with these signs and symptoms of pneumonia plus any general danger signs like inability to drink, persistent vomiting, convulsion, lethargy, stridor, or severe malnutrition. And there are other factors or criteria as expounded by IDSA in its 2018 classification that severe pneumonia are those children can be classified under severe pneumonia if they are not feeding, they have nasal flaring, they have cyanosis, apnea, grunting, tachycardia, signs of dehydration, or a capillary refill of more than 2 seconds. Why is this classification important? The severity of the pneumonia is classified based on the risk for pneumonia-related mortality in such a way that non-severe pneumonia or the plain pneumonia are those with low risk for pneumonia-related mortality and can therefore be treated at home. And those with severe pneumonia are those with high risk for pneumonia-related mortality and may need to be admitted to a healthcare facility with IV antibiotics and maybe referral to other specialists. Among the ancillary tests used in the diagnosis of pneumonia, we can use pulse oximetry as part of our diagnostic aids, just like the use of our stethoscope. It helps us identify patients that may need oxygen therapy and therefore aid us in our plans for management of this patient on whether to admit our patients or not. There had been recent evidences in literature on arbitrary values of hypoxemia among children with pneumonia. Suffice it is to say that all these other researches are done to look into the relationship of hypoxemia to risk for mortality, risk for morbidity, and diagnosis of pneumonia. But for this particular issue, we suffice it is to say that a saturation of more than or equal to 95% is normal. Among the ancillary tests or laboratory tests that we can also look into are your complete blood count, your inflammatory markers, your cultures, and your PCRs. However, routine testing or routine use of these laboratory tests are not indicated to make a diagnosis of pneumonia, and especially for those patients who are treated on an outpatient basis. There is a need for these laboratory tests to serve as baseline or to serve as a monitoring tool, especially for those children who are admitted. Identification of the possible etiologic agents are done by the use of your cultures and use of your PCRs. However, the viability of the effect of the organism is not shown in PCR as compared to cultures. Another diagnostic test that can be done are the diagnostic imaging, and we have two. That is the chest radiography, who have been the reference standard in the diagnosis of pediatric community acquired pneumonia. Its standardization has been done as early as the year 2000. However, recently, there is an increased awareness and use of lung ultrasound as a new imaging application of sonography, mainly because of its portability and the ease of use in a skilled operator. It's also being used as a point of care ultrasound, meaning you have a handheld ultrasound that you can use just like your stethoscope and just like your pulse oximeter. There have been teaching and training modules that are being done in foreign medical schools on its use as a focus or point of care. However, these modules have just been recently introduced into our local medical school. So maybe in a few years, maybe in 5 years or even in 10 years, we can see our doctors bring in their portable ultrasound as part of their diagnostic aids, just like the stethoscope and just like the oximeter. So let us now look into some images of chest radiographs in pneumonia. The above image is that of a bacterial pneumonia. Findings that includes a rounded area of airspace consolidation in the superior segment of the right lower lobe with few air bronchogram seen medially. And the lower image is that of a viral pneumonia that shows hyperinflation with mild peribronchial coughing and increased parahilar markings and patchy lingular opacities that may represent atelectasis. These are hallmark findings for bacterial and viral pneumonia. However, the use of chest radiography to identify the organisms, the etiologic agents in pneumonia has never been studied or is not done until present. A few reminder that chest radiography should not be routinely obtained in children with acute uncomplicated lower respiratory tract infection. It is not a good indicator of the etiology or the causative agent, and follow-up chest x-ray is only useful after a lobar collapse, apparent pneumonia, or persistence of symptoms when we are re-evaluating our patients. Let's now go to lung ultrasound. In recent years, it's being used. There are so many reported studies on its use as a substitute for chest x-ray in pediatric pneumonia. Its sensitivity is as high as 86% and its specificity is as high as 89%, meaning that those patients with true pneumonia really have the lung ultrasound positive findings, and those patients who do not have the lung ultrasound findings do not really have pneumonia in 89%. So how do we now look at this lung ultrasound? I have tabulated the differences and the comparison between ultrasound findings in bacterial pneumonia and viral pneumonia. If you look at this, you will see that the distribution in bacterial pneumonia is in the posterior lung zone. In viral pneumonia, it's outrightly diffuse. Pleural lines are irregular in both situations. However, there are more pleural lines noted in areas of consolidation in bacterial pneumonia. The lung parenchyma, there are discrete B lines in both. However, there is a tendency for the B lines to be confluent in viral pneumonia. Just as well, there are consolidations in both bacterial and viral pneumonia. However, there is a tendency for this consolidation to be focal and for hepatization in bacterial pneumonia. And in viral pneumonia, consolidations are sub-centimeter. The most common findings that can actually differentiate the two is the presence of pleural effusion, which is more common in bacterial pneumonia and very rare in viral pneumonia. So when we do use the probe, the ultrasound probe, where should we look into? Based on these affected lung zones, it's in the posterior lung zone in 45.6%, and therefore the best area to put in the probe is in the infrascapular area at the back, wherein we will see consolidation mostly in the lower lobes as compared to the other lobes, the upper and the middle lobes. Let me now guide you through these ultrasound images. The topmost portion is the portion near the probe, and there would be an inverted, the view will be just like an inverted V, so that a normal lung in a lung ultrasound will have the A-line pattern, meaning that contrast is between the ribs, which is radiolucent, as compared to the lung parenchyma. This is a sub-centimeter consolidation at the pleural lines in between the two ribs. And this is a focal consolidation with air bronchograms. And this is a dense consolidation that looks just like the liver and is termed as hepatization in bacterial pneumonia. Let's now look at the ultrasound findings in viral pneumonia. A normal lung will again still have that A-line pattern. However, there are discrete B lines that originates from a regular pleural line in viral pneumonia with tendency for confluence of these B lines. And we can also see a sub-centimeter consolidation in the pleural line in viral pneumonia. Lung ultrasound does not replace our chest radiography because it needs skills of the operator as of the moment. And therefore, if our graduates or our trainees or our medical students have the skills to do this, then maybe there might be a role for lung ultrasound as a point of care in the local setting. As far as the pneumonia treatment for infants and children less than 5 is concerned, we look into the National Antibiotic Guideline, looking into the possible etiologic agents, bacterial etiologic agents, and that is strep pneumoniae in 30 to 50%, H. influenzae type B in 10 to 30%. In some situations, we have Staph aureus, Klebsiella pneumoniae, non-typable H. influenzae. And it is because of these possible etiologic agents, that's why we have these recommendations on the use of the antibiotics for bacterial pneumonia. In the outpatient management, it depends on the Hib vaccination of the patient, or whether the patient is complete or there is no Hib vaccine or an incomplete or unknown vaccine history. The drug of choice actually is amoxicillins, co-amoxiclav, or even cefuroxime. And these antibiotics of choice has been there, or has been the recommendation even by WHO since 2012 or 2014, because it has been well studied. Amoxicillin has been well studied because among the molecule, amoxicillin has a longer duration above MIC of more than 40% of the time, to have a bactericidal effect of 85 to 100% among the possible causes like strep and H. influenzae. If you're allergic to amoxicillin, you may have to consider using macrolide. If there's non-response to treatment in 48 to 72 hours, if started on amoxicillin, may shift to co-amoxiclav. However, if started on co-amoxiclav, there may be a need to admit patients for IV antibiotics. May also consider adding oral macrolide or considering other diagnoses as part of the management plan for a non-responsive pneumonia. Just as well, in inpatient treatment, with complete HIV vaccination, PenG and ampicillin are the drugs of choice. If there are no HIV vaccination, incomplete or unknown vaccination history, there are options to use ampicillin sulbactam, cefuroxime, or ceftriaxone. There is also a recommendation on when to switch from IV to oral 2 to 3 days after initiation of treatment in patients who are responding to initial treatment, who are able to feed, who are free from pulmonary, extrapulmonary complications. The usual total course of therapy is about 7 to 10 days for uncomplicated pneumonia, or 2 to 3 weeks for more severe disease or if with complications. However, recent studies have shown and have looked into the use of shortened course of antibiotics, like 3 to 5 days, for those patients with uncomplicated pneumonia. There is also a recommendation that if there is no response or worsening condition, a referral to a specialist and admission to a critical care unit is advised. So, with pneumonia in children more than 5 years or among adolescents, the clinical presentation is relatively indistinguishable whether the causative or the etiologic agent is a bacterial or a viral pneumonia. Complaints are usually related to the slowly progressive systemic symptoms that is seen over 3 to 7 days, with malaise, pharyngitis, headache, followed by irritative and non-productive cough, with a total duration of 2 to 4 weeks. There might be physical examination findings of crackles, rhonchi, wheezes, in a child who seemingly appear well and does not appear ill, and with the term like walking pneumonia. Let me guide you through these 3 algorithms before I finish with my presentation. Why do I look into pneumonia with parapneumonic effusion? Mainly because these patients, in some situation, this patient may respond just to medical management, and we as clinicians should know and should look into this algorithm. 1, with a pneumonia, whether with or without effusion, the first line is IV ampicillin. If there is penicillin allergy, we may have to use ceftriaxone, or in cases of beta-lactam allergy, the use of levofloxacin. If there is a suspected or confirmed influenza, we may have to consider co-infection. We may have to consider using other antiviral agents. For atypical pathogens, we may have to consider using or adding on macrolide, and we may have to consider evaluation by or referral to a specialist for possible if there is a possibility of exposure to unusual pathogens. For patients whom we need to cover for MRSA, we can add clindamycin or vancomycin. Just as well, when organisms are identified and there is a susceptibility, there's a susceptibility or sensitivity test done, we may have to tailor fit our therapy depending on the organism identified and the susceptibility to the antibiotics. So as clinician, we have a role in managing these patients with pneumonia, even in the presence of parapneumonic effusion. For those small effusion with no respiratory distress, we can start empiric IV antibiotics, and in majority of cases, they do respond to just IV antibiotics. However, in the presence of mediastinal shift, the presence of respiratory distress, or possible loculation, then we may need to refer this for interventions, like putting in a chest drain with or without fibrinolytics, having this pleural fluid analyzed, cytology, biochem, cultures, PCR, and do the targeted antibiotics. If there is no response to our chest drain and we need to go more invasive, then we can do video-assisted thoracoscopy. And if there is still no response, then we may have to refer and outrightly, in the presence of complication, consider major surgery or a thoracotomy for these particular groups of patients. This is just a proposed algorithm for pneumonia. In the presence of fever, cough, dyspnea, you might consider diagnosis of pneumonia. Severity classification based on the risk for mortality are non-severe pneumonia and severe pneumonia. And we have options to treat this patient. Check its response to empiric treatment within 24 to 72 hours and complete treatment if there is a good response. However, if there is poor response to treatment at any time frame or time point within the next 72 hours, then we might have to consider other diagnoses, or we might have to consider polymicrobial pneumonia. We may have to consider antibiotic resistance, or consider the presence of complications of pneumonia. Consider other non-infectious causes and presence of comorbidities. And at any time frame, we can also do our referral to a specialist, especially if our patient has severe pneumonia or if our patient is not responding to our empiric treatment within the next 24 to 72 hours. So far, I have run through some key points as to the burden of disease. We have seen that pneumonia is still a top leading cause of morbidity and mortality despite the advent of vaccinations and despite all the health measures being given or health programs offered by our government. As far as diagnosis, we have simplified the diagnosis of pneumonia into that with non-severe and severe pneumonia, mainly to help us in our plans of management on whether to admit our patients or not because of the increased risk of pneumonia-related mortalities for those children who have severe pneumonia. We have looked into some of the ancillary and even the imaging tests. Suffice it to say that there are no routine tests to be done if we decide to treat our patients in an ambulatory setting. However, there might be a role in the use of laboratory or imaging tests if we do decide to admit these patients. And as far as our diagnostic aids are concerned, we have to look into the use not just of our stethoscope, but the use of our pulse oximeter to help us to aid us in our management. We have looked into some of the treatment plans or the antibiotics being used in the management of bacterial pneumonia and some algorithms that will help us identify and simplify our management plans or treatment for these particular patients. So before I end, let me show to you my references. And I would like to ask you to stay tuned because the updated PCAP CPG will soon be released, maybe by the end of this year or maybe early next year. And I hope that with this, my presentation, it will outrightly review you with community-acquired pneumonia. So thank you very much for listening and stay safe, everyone. Thank you.
Thank you, Dr. Maria Nerissa De Leon, for sharing a very insightful lecture. Once again, we welcome your comments and questions in the chat box. Our speaker will gladly answer them for you. So at this point, allow me to present the certificate of appreciation to Dr. Maria Nerissa De Leon for being our speaker in the 12th Biennial Symposium Exploring the New in Pulmonology, given this 16th day of September 2021, signed by Dr. Cesar Antonio Ligo, President of the PFL-HRD, Dr. Eileen Banson, Head of the Division of Pulmonary and Critical Care Medicine, and the members of the organizing committee. Thank you everyone for attending day one of our convention. I would like to remind everyone to answer the survey form provided after the last lecture for you to be able to receive your CPD units. Before I leave, I would like to invite you to join us in the Pfizer Dinner Symposium to be followed by McGraw-Corbridge After Dinner Symposium. Once again, this is Dr. Arnold Lim saying good night and see you all tomorrow for the day 2 of our convention.